Okay, so this PowerPoint is, I would say, probably one of the more important PowerPoints of this whole unit. Most of this unit is very surface. We don't go into a lot of detail about things. We throw a couple things to memorize on a flashcard, but we're not really thinking about the concept or the process very much. This, however, is one that this PowerPoint, I really want you guys to feel like you have good comprehension on, because this is going to follow you through the rest of the program. This has a lot of different applications. This has a lot of clinical applications that I use in my daily life as an RT all the time. So kind of the way that I see this going is, so that the PowerPoint recording doesn't get too long, I'm going to do a quick overview here that you guys can listen to at home over the weekend and get an idea of what we're going to be talking about. And then on Tuesday during lecture, we're going to go through it again in even more detail. So if you have questions, email them to me beforehand so I can kind of look at where some of the struggling points are. But just know that there's going to be an essay about this on your quiz, and this is going to be a bulk of the points. So we're going to talk about central and peripheral chemoreceptors. Your central chemoreceptors are located in your medulla. Your peripheral are located in your carotid and aortic bodies. So those are the major arteries coming off of the heart. So this is your oxygenated blood that's going out to your bodies, and these receptors are there kind of measuring things, essentially, okay? So quick definitions for reference. CSS, cerebrospinal fluid. BBB, blood-brain barrier. Hydrolyzed in this unit, or in this PowerPoint, what we're talking about specifically is the hydrolysis of CO2. All hydrolyzed means is a component or a compound mixing with water, and what happens. Now, we talked a lot about CO2 transport. Most of how CO2 is transported is in this ionized bicarbonate reaction, where CO2 mixes with water. It makes this H2CO3, or this weak acid, which then dissociates into HCO3 and H+. This is very important for this unit and understanding how these chemoreceptors are stimulated. So knowing that this reaction can go both ways, and that CO2, the production of CO2 does make more H+ ions, and also that way backwards. So just really link those in your minds, and it's going to help you as we move forward. Central just means the brain or the medulla. Peripheral is the carotid and aortic bodies, those major arteries coming off the heart. So chemical control of breathing. Your body is always working to maintain proper levels of oxygen, CO2, keep that pH nice in the 7.35 to 7.45 range, right? We're pretty familiar with this with our blood gases. And the way that it's going to do that is with these chemoreceptors that are going to try to keep our minute ventilation where we need it, okay? And when you think about minute ventilation being our tidal volume and our respiratory rate, with the goal of always meeting our body's metabolic needs, right? We're going to talk about how that happens in detail. This is stuff we already know. Now we're going to look at like the finer tune elements of it. So you have central chemoreceptors. These are located bilaterally in your medulla. They are stimulated directly by H+ ions, okay? H+ ions are these guys right here, okay? H+ ions are what stimulate them. If you have more H+ ions, you're going to have a stronger signal that's going to make you breathe more. If you have less H+ ions, it's going to be a weaker signal. It's going to make you breathe less. So they're stimulated directly by H+ ions, indirectly by CO2, okay? And I'm going to explain why that's important here down here. So your blood-brain barrier is almost completely impermeable to H+. What does that mean? It means that H+ can't actually make it into your brain, right? So how does it get there? Well, CO2 does cross your blood-brain barrier. It can pass freely through there. So now you have CO2 that's passing into your brain, right? Look down here. It's going to mix with your cerebrospinal fluid. That's going to cause hydrolysis, or it's going to hydrolyze that CO2, right? So all that means is that CO2 is going to mix with water. It's going to make this weak acid, and it's going to dissociate into this bicarb and this H+. Well, this is the H+ that's then going to stimulate that central chemoreceptor. If you have more CO2, you will have more H+, which will stimulate that breathing even more. So think of an example of how this would happen. If you're exercising and all of a sudden your CO2 production is going way up, that's going to be more CO2 is going to go through that blood-brain barrier. It's going to mix with that cerebrospinal fluid. It's going to get hydrolyzed, and it's going to release more H+ ions. That's going to tell your body, whoa, 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 I need to breathe more. I have way more CO2 production happening. I need to breathe and get this out. So that's how that works. So an increase in CO2 will increase your H plus. That's going to cause your breathing to increase, right? And the goal is to keep those pH levels and CO2 levels normal. If you have less CO2, you're going to have less H plus, a weaker signal. That breathing is going to slow back down. So this is kind of a summary of those steps. So decreased ventilation is going to increase PaCO2, increase CO2 in your cerebral spinal fluid. The hydrolysis happens. That's going to increase the H plus, decrease the pH, and then you're going to have this stimulation. I know this is confusing. When I say it out loud, it sounds confusing, but you guys know most of this, right? You know that if you breathe less, that your arterial CO2 goes up. That's something you guys already know. That's called hypoventilation. You guys know that. That's a concept that you get. You also know that your ventilation is what gets rid of your CO2. We talked about this with your respiratory rate and your tidal volume. So that's not new information. You guys, we did the CO2 transport, so we already did a lot with this ionized bicarbonate where CO2 goes into H+. So that's not new. You guys also know that if you have a high CO2, that you have a low pH because that's an acidic pH and this is your acid. So that's not new. The new part is this central chemoreceptor and how it responds. So a lot of this information is information you guys already know. So try to remember that. Don't get too overwhelmed by it. It's not all new. This is just kind of a quick diagram where it shows that hydrolysis in that cerebral spinal fluid, and it shows the way the H plus would then affect those central chemoreceptors. You don't have to memorize this diagram. It is strictly just so that you have a visual as we move through here. The second chemoreceptors we're going to talk about are your peripheral chemoreceptors. They are a little bit more, I don't want to say tricky, but there's kind of an addition that we need to talk about with them. So we've said it over and over and over again. CO2 is what drives ventilation. CO2, not oxygen, is what drives ventilation. That is still true, but there's a little bit of a caveat. With your peripheral chemoreceptors, your arterial oxygen starts to play an indirect role. And this is how. You have to think about the fact that your peripheral chemoreceptors are located on your aortic and your carotid arteries. These are the arteries right off your heart. So this is your oxygenated blood leaving your heart going out to your body. And they measure the arterial content of oxygen, the pressure of oxygen in that blood. And if you get to around 60 or lower, right, which would put you at moderate hypoxemia or less, right, what that does is it makes your peripheral chemoreceptors more responsive to H+, right? It's a secondary kind of reflex to help you to increase your minute ventilation if you're having poor oxygenation, all right? So under normal circumstances, oxygen plays no role in the drive to breathe. But when you start getting hypoxic, specifically to levels of 60 or less, now all of a sudden oxygen can contribute to that drive to breathe. This is how. So central chemoreceptors respond directly to that H+, right? And we talked about how this works with the CO2 because of the blood-brain barrier, right? This is the primary way that you breathe. Almost everybody, most of your breathing, 90% of your breathing comes from these central chemoreceptors, right? You have this secondary kind of system in place. This is the less direct way, the less primary way that you breathe, but it's still receptors that you have that control your ventilation. They also respond directly to H+, okay? So they're still responding to that CO2 through H+, but they have this secondary effect here. PO2 either dulls or enhances H+ sensitivity. So if you're hypoxemic, specifically less than 60, it's going to make these peripheral receptors much more sensitive to H+. So what does that mean? It means that if you're more sensitive to something, you're more likely to respond to it. So you could have a certain level of H+ in your blood, right? And then if all of a sudden you are now hypoxemic on top of that, that H+ is going to make a signal where maybe before it wouldn't, because the body is recognizing that, whoa, for some reason there's not as much oxygen leaving the heart as there should be. We need to kick up our ventilation. We need to bring in more, right? And this is still happening because of the H+. This is still happening because of the CO2, but now there's almost a secondary mechanism that just helps to either enhance or dull the receptor's response to that H+. All right? So control of breathing in chronic hypercapnia gets a little bit more confusing. So kind of the concept that we're going to dig into for this is people who have high CO2 all the time, right? So these are your very severe COPDers who constantly have high levels of CO2 in their bloodstream, higher than normal. How is their breathing happening? Okay, so if you are a normal person and you have a sudden rise in PaCO2, that's going to cause an immediate rise in your minute ventilation. All right, we talked about this. When you're exercising, I know this is an example we give all the time, but it's the best example. When you're exercising, all of a sudden your CO2 production goes way up. Your body immediately, I mean, you can relate to this because it's something we've all experienced. Your body immediately increases your respiratory rate and your tidal volume. That happens very quickly, and it's doing that because it's getting rid of that CO2 that you're now producing, right? If you have slow rising PaCO2, like in somebody with severe COPD, what happens is your kidneys have time to respond. And we know from our studies of blood gases that your kidneys will respond by retaining bicarb, right? You start to get higher and higher levels of bicarb. And what this is going to do is it's going to buffer that CO2, or it's going to balance it, because this is your base and this is your acid. So it's not like with a severe COPD, or like when you're exercising where you have this quick jump in CO2, their lungs slowly deteriorate and their ventilation gets worse and worse and their gas exchange gets worse and worse. And so as this is happening over years and years, the kidneys start retaining and buffering that so that they can keep that pH normal. All right. So what ends up happening is they actually blunt or buffer those central chemoreceptors from recognizing the H plus and responding to it. Because if you look back at this ionized bicarbonate equation, right, you have the CO2 plus H2O goes into this weak acid, and then you get HCO3 and H plus. This is what your kidneys are producing. So if they have the time and they produce way more of this, that's going to make it bond back with that H plus, and it's going to go backwards through this, and it's not going to do the thing that it needs to do, which is stimulate your central chemoreceptors. So I know you guys are super enjoying this. Just bear with me. We'll get there. So because this is a slow process, it basically makes it so your central chemoreceptors are not very effective. They don't do what they're supposed to do. They don't alter your ventilation. So then what happens is these patients also generally have a certain level of hypoxemia at baseline. Again, the same damage that is happening to their lungs that is hurting their gas exchange of CO2 is also going to hurt their ability to oxygenate effectively. So they become more reliant on their peripheral chemoreceptors than somebody with healthy lungs. The reason why is that hypoxemia that they have will make their peripheral chemoreceptors more sensitive to the H plus. So it helps to get rid of that buffering effect, and that actually will drive their breathing. The reason that we care about this is if you have a patient that comes in with a COPD exacerbation, they're not oxygenating well, let's say their SpO2 is 70%, so you put them on oxygen to correct that. And if you don't pay attention and you don't wean them off their oxygen as you start to give them nebs and correct whatever problem they're having, or they get over that acute phase, and all of a sudden you allow their oxygen levels to get very high, like much above 60, what you're going to do is you're going to knock out their peripheral, those peripheral chemoreceptors, and you're going to knock out their drive to breathe. They're not using their central chemoreceptors because they've had high levels of CO2 for a long time. So they're really relying on that secondary, those peripheral chemoreceptors and that hypoxemia to kind of push their breathing. If you knock out that hypoxic drive by making their PaO2 get too much higher than 60, well, now they can get in trouble. They don't breathe as much. That can cause that CO2 to build up even more, and it can get them intubated, or it can really be a dangerous thing for them. So this is called oxygen-associated hypercapnia. So the O2 therapy you put them on may cause a sudden rise in PaCO2 because it basically slows down their breathing and can really kind of compromise their ventilatory status. I will give you some examples of this. And again, this is the first time through this, so just realize we are going to have another detailed lecture on this. But there's 3 reasons why they think that this can happen to severe COPDers. And it has to be pretty severe. Like they would have to be what's considered a chronic retainer. And how we define chronic retainer is somebody, if you drew a blood gas, if their bicarb was much higher than normal, that would show us that over time their kidneys have released that. And this is a chronic condition, that this is something that this person has at baseline kind of all the time. So the possible explanations for why putting a chronic retainer on oxygen therapy can do this is, one, the hypoxic drive, which is what we talked about, where basically if you have their PaO2 get up much higher than 60, then those peripheral chemoreceptors are not going to be as sensitive to the H+, and so that will slow down their breathing. That's one reason. The other reason that their CO2 gets much, much worse is because if you put them on oxygen, it's going to vasodilate their pulmonary vasculature. So we talked about pulmonary hypertension and cor pulmonale in the previous unit, and that's caused by people who are chronically hypoxemic. You have vasoconstriction of the different capillaries because of those local controls in the lungs, trying to guide blood to areas of the lungs that are better ventilated. If you put somebody on oxygen, all of a sudden their PaO2 is a little bit better than it normally is. All of those previously vasoconstricted blood vessels are now going to vasodilate because they're kind of almost being tricked. They have all of this extra oxygen that they didn't have before. That alveolar oxygen is higher because you've increased that that gradient by putting them on supplemental oxygen, so they can vasodilate. That can end up putting blood in areas of the lung that is not very well ventilated. So you can worsen your VQ mismatch, and we know that that will hurt gas exchange. The third reason this FiO2 may make patient susceptible to absorption atelectasis, as I'm saying this out loud, what I want you to do is mentally cross that one off the list. I'm not going to go into that now. I think that's going to muddy the waters, and yes, I'm going to delete it out. So that third one right now, just in your mind, that absorption atelectasis, we're not going to talk about that. That's going to muddy the waters. We're not going to do it. So we'll X that off. That'll be discussed at a later date. I'll delete it from the PowerPoint after I'm done here. So those are the 2 things that we're going to be looking at in detail come Tuesday. So chemical control of breathing continued. So these are kind of the key points. COPD, just having COPD does not necessarily mean that you have chronic hypercapnia. You can have COPD and not be what's considered a CO2 retainer. So just be careful with that. These are more end-stage disease or people that are, I don't want to say very sick because they don't necessarily have to be very sick, but there's a very specific blood gas where you have a high bicarb. It takes kidneys a while to reabsorb bicarb. This is not something that happens quickly. So you would be able to see that somebody had long periods of high CO2 based on how high their bicarb is. So that makes it more of the population that we're talking about. Most of the time, oxygen-induced hypercapnia or acidemia is not really warranted in most COPD patients. This is a very specific population that we're talking about. You should never withhold oxygen from a hypoxemic COPD patient, no matter what, ever. If somebody comes in, whether they're a retainer or not, and they are not saturating well, you're always going to give them oxygen. You're always going to fix that first. That being said, if you have a patient that is a chronic retainer that could be at risk for this and you put them on oxygen, you need to be prepared that they might need more support, either with a ventilator or a BiPAP, because you might knock out their drive to breathe by fixing their hypoxemia. The other thing that you really want to pay attention is a lot of the times these patients come in because they have an exacerbation. You give them nebs, you give them steroids, you fix some of those problems and allow for their ventilation to get better. And in doing so, if you're not weaning that oxygen down pretty quickly to target a PaO2 of around 60, then those patients are kind of the ones that are at risk for this, where it can slow down their drive to breathe and it can allow that CO2 to really build up in their system. So again, I know this is a lot for a recorded lecture. This is just the overview. So I want you to take the time to look through the PowerPoint, get familiar with the terms, and then we'll do a lecture together on Tuesday. So again, in a normal lung, which drives the breathing, O2 or CO2? It is the CO2. I really want you guys to absolutely understand that. You could decrease your ventilation by half. So you could stop breathing 50% of the time, and your PCO2 will double because of that. But your CaO2 has almost no change. So the content of oxygen in your blood does very little to change when you decrease your ventilation, but your CO2 very quickly will double. If you double ventilation, your PCO2 is going to drop by half. And again, that oxygen content will have no change or very little change, okay? There's a lot of reasons this happens, but I really, just because we're talking about peripheral chemoreceptors having this secondary thing that makes them more or less sensitive to H plus with oxygen, that doesn't change the fact that CO2 is still what's driving it. Okay, this is a very unique thing where people with chronic hypercapnia are almost blunted by the CO2 and more reliant on the oxygen. This does not happen for the normal healthy population. So I just really want to make sure we're clear on that. These are your questions. Real quick point here, I have this at the end. So explain in your own words why a patient with chronically high CO2 will have their ventilation compromised if their PaO2 rises much above 60. Try to be as detailed as possible with this question. It will be an essay question on your quiz worth a decent amount of points. So if you email me your answer to this question at least 2 days before the quiz, I will give you feedback on whether or not you are actually understanding this. My recommendation is that you do this. Because truly my goal for this is comprehension. I don't want you to memorize it. I don't want you to try to study it and be wrong and then not do well on the quiz. I really want you guys to feel like you understand this. So when you are ready after our lecture on Tuesday, after we've talked about this in more detail, I want you to write in detail, which means using things like the central chemoreceptors respond directly to H plus and indirectly to CO2. I mean, really detailed. Send it to me and I will tell you if you're on the right track, and then you will already have your answer for a big question on the quiz. That is all I have. And then I will just plan to see you guys Tuesday and we'll go over this PowerPoint then. That's it.